everybody. Welcome back to my channel, Do Life with Jackie. Hello, good evening, good morning. I don't know when you're watching this. It is good to be back. Welcome to my second video. I'm so excited to be here again and just having a discussion with you guys. So today's video is basically about what is it that dietitians do? Because I know a lot of times people, they hear that I'm a dietitian, but they don't really understand what that means and what all that entails, right? So I felt like, why not take a video to like break that down and really get to the nitty gritty of what it is all that we do. I feel like that is very important for you to know that and for you to understand, like, okay, what is it that we do? So drum roll, please. So what is a dietitian? So I actually took to Google because I was like, it's one thing for me to have an idea of what I am and what I do, but what does Google say that I am? So Google says that we are experts in diet and nutrition. So I am an expert. Look at, I'm an this is the look of an expert, okay? Anywho, okay, so there are many different types of dietitians, and I took some time to like make a list. I'll try to either put it in the description or add it to the video. Not really sure which one I'm gonna do right now, but either or, you'll see the list somewhere. So there are different types of dietitians. There are bariatric dietitians, clinical dietitians. I'm technically a clinical dietitian. I don't have to just be a clinical dietitian, but I typically have only worked mostly in the clinical realm, whether that be adults or with pediatrics, so kiddos and everything like that. Also, as like a clinical dietitian, you can work in specific disease states. So it could be like cystic fibrosis, it could be transplant, it could be kidney disease, anything like that you can specialize in and stuff like that. There's even diabetes educators for dietitians who specifically want to work with diabetes patients. So there's a lot of specification there in the clinical world. And outside of clinical, there's a food service dietitian, there is a sports dietitian, there is a research dietitian, there are dietitians that just teach. So you become a dietitian and you just teach at a college or at a high school or whatever, but you can teach at different levels depending on how much experience that you've had and like your degree type, right? There's also WIC dietitians, so dietitians that work at the women's, infants, and children's clinics and stuff like that to help women that have infants, of course, women's, infants, and children. And yeah, you get the gist of that, right? What else? Oh, yeah, you can be a dietitian on a college campus. And so those dietitians typically just do the basic like counseling, like if any of the students have any questions. They may have make sure the food service staff are up to par on food safety and stuff like that. Because I did a part of that in my internship. So that's how I know about that. I think I mentioned the food service dietitian too, and that was when we were working like in the school districts and stuff like that, making sure that like the kids that had the national school lunch service, that they were meeting the specific micronutrient and macronutrients, so like carbs, fat and protein or macronutrients, and then like the vitamin mineral needs that they're supposed to be meeting each day, because it's very specific. So to be that food service dietitian, you have to be very meticulous. Not for me, but it is a job for somebody. And there are a lot of people who love just working with kids and being in the school and being able to impact them in that way. So that's just a quick list that I thought of, like different areas that dietitians can work in. But just with that, there's a lot that we do, right? And so a lot of what I'll be sharing will be mostly what we do as far as like being clinical dietitian, because that's specifically what I do. I mean, obviously what they may do in food service versus what they may do as a sports dietitian and different things like that. A lot of that stuff will be more variable, but a lot of it is the same. So for instance, what is it that dietitians do, right? On a normal day-to-day basis, what will you see us doing? So we may be doing diet educations, tube feedings, TPN, or parenteral nutrition. I don't know if I just said that right. I've said it wrong so many times, whatever. But that's the type of nutrition basically where we're feeding you through a peripheral line that goes here, and it goes through a vein that's connected to the heart. Or is it an artery? It's one of those. I always get it confused, but close enough. It goes into your arm and it goes here with it. Yep, you see how here with it. Okay. We do nutrition counseling, so helping people like counsel them on anything like diabetes. Like maybe we're trying to help them change a habit, and maybe they have some behavioral issues or some beliefs that are getting in the way of that. We help counsel people through that. We calculate their energy and protein needs. We calculate people's fluid needs. We have to be aware of medication versus food interactions. We have to coordinate care with other providers, meaning we have to have talks with doctors. We have to be able to talk with the social workers. We have to be able to talk with different members of the care team, depending on what's going on with the patient, right? We have to do nutrition-focused physical exam. And what that is basically where we're assessing people's fat and muscle stores. Like we have to go along their body and be like, okay, what is the fat and muscle feeling like? Just from what we're palpating across their body, like what does that feel like? Do they have a lot of fat? Do they have a lot of muscle in this area? We have to be able to look at them and see if they have any micronutrient deficiencies. So vitamin C deficiencies, like one of the signs of that would be like petechiae, and it'd be like these little red spots all over your body. And different stuff like that we have to be aware of. Now that's just an example. There's a lot more micronutrients and deficiencies and different things we have to be aware of. I don't remember everything off the top of my head because I'm not just like a big old dictionary with all these little things just in my head. I have to review a lot of this stuff sometimes, but these are just some of the things we have to do. I'm trying to remember, am I forgetting anything? No. Okay. So yeah, I say diet education, tube feeding and stuff like that. And so those are some of the things that we do just on a general basis. So typically when we're having to assess specifically in the hospital, we're going to be using the ADIME format. And so what the ADIME format is, it's assessment, diagnosis, intervention, monitoring, and evaluating. And typically we do this because we want to be able to break it down so you can have basically the way I've always thought about ADIME is like that's our way of stating our case for why we're doing what we're doing. So when you're doing an assessment, you're going to review the patient's lab values. You're going to review the doctor's notes to see what information you need to pull from that to be able to state your case for this nutrition problem that you're going to create. I'll get to that in a second. You're going to want to review medication, surgical history, past medical history, weight history, diet history, and also, like I said, NFPE, which is nutrition focused physical exam. That would be a part of your assessment as well. And once we finish reviewing all the information, then we create a nutrition diagnosis, right? So say that I have a patient hadn't been eating for like the last month, or if they've been eating less than 50% of their energy needs or whatever, right? For like the last month, and they have like 25 pounds of weight loss, or, and I do nutrition-focused physical exam and check out different areas of their body, and I see that they have muscle and fat wasting, right? Then I could possibly do a malnutrition diagnosis, and it would be something like, severe malnutrition related to inadequate energy intake as evidenced by, 16% weight loss in 1 month. Intake, meaning food intake, oral intake, of less than 50% for greater than or equal to a month. Like that would be an example of a diagnosis. And so once we form that diagnosis because like I said, the diagnosis is formed after you after you do that assessment. And then once we have diagnosis, like, okay, what are you going to do to intervene, right? So we have a diagnosis and we're like, okay, we have to have an intervention. What are we going to do to fix this problem, which is the diagnosis? And so in the hospital, typically our options are going to be like either oral nutrition supplements, so like a Boost or Ensure. I mean, people like Orgain too. That's more of I think we have that's like a vegan option too. We may consider appetite stimulants. We may provide diet education. If a person really can't meet their nutrition needs by mouth alone and they're really, really malnourished, we may have to do tube feedings, and that's why I mentioned like what dietitians do earlier, because a lot of these things we're doing over and over just in different ways, right? And so once we would do these interventions, then we'd have to monitor and evaluate. And the reason why that's so important is because you want to see if what you're doing is working. You don't just do a diagnosis and an intervention and be like, oh, that's it. We're done. We solved the problem. Bam. No, because a lot of the time it's not that simple. You may recommend a supplement and the patient like freaking hates it. And then you're like, oh, well, you haven't been drinking it. Okay, let's try something else. That's why you have to keep reevaluating what your recommendations are, because things change, patients change, their wants and needs may change. Like it's a very quick pace way of thinking, you have to really stay on top of things, because you can't just think you're going to do this one intervention and then that'll just solve everything. That's not usually the case. Sometimes it can be one and done. Like maybe somebody has a high blood sugar and then they just haven't been eating very well because they just need some education. We give them education and bam, they're good to go, right? But a lot of the times it does take a little bit more than that. So that's something to be aware of. And when it comes to like what dietitians do. And so for me specifically as a clinical dietitian, because I typically work clinical, I've worked clinical inpatient with adults and clinical outpatient with pediatrics. Mostly, I guess if I can just summarize like in general, the areas I've worked in. So being a clinical dietitian, I work with ICU patients. So intensive care unit, those would be the critical care patients. A lot of them, if not all of them, are going to be on tube feedings, or they're going to have some type of ventilator support because they can't breathe on their own. Neuro patients. So that could be anybody from neuro ICU. So maybe like the patients who had a stroke and then they are doing so bad that they need intensive care. So they need to be on like some type of ventilator, some type of pressor, which a pressor is something that helps to maintain blood pressure. Basically, it can help keep it steady to where you're having a certain amount of pressure over extending a period of time. You want your pressure to be stable, because if it's fluctuating a lot, that means that you're not stable. I deal with cancer patients, so that'd be oncology, gastroenterology patients, would be considered our GI patients, and that could be anything from somebody who has, so they have an obstruction in their small intestine, right? That's something that we dietitians would have to be able to help with. We're a part of the care team, and so that would be something important for us to be aware of. And then maybe we have to decide, okay, can we bypass the obstruction to be able to feed into this part of the small intestine, or do we just have to just completely bypass the GI tract and just do TPN? Because TPN is something that you would recommend in a situation where you cannot feed through the GI tract. So that means you can't do nothing with the esophagus, the stomach, the small intestine, large intestine, any of that. Like you have to just not get rid of it, obviously, but you have to just bypass all of that and just feed a different way. Excuse me. I also work with renal patients. So that could be anybody who has like chronic kidney disease, or a lot of patients that are on dialysis as well. That's something that we have to be aware of. Of course, cardiac patients, so patients with like heart disease, patients who have had like heart surgery, stuff like that's important. Surgical patients, so that could be any type of surgery. Like I know a lot of times we have patients who are status post a CABG, and I'm not going to go into what a CABG is, but it's basically a coronary artery bypass graft, and it's a heart surgery some patients have to get. And they'll be in the SICU, which is the surgical ICU, because, they may not be fully stable. So they can't really go back to like a regular floor. So they put them in the surgical ICU to monitor them. And then they may transfer them to like a regular floor for people that are a little bit more stable. And then there's a transplant. I have to deal with transplant patients. So patients who have had lung transplants or planning to get lung transplants. Patients who've had liver transplant or are planning to get liver, kidney, or planning to, like, all those things are things that I typically have to deal with being a clinical dietitian. And, I really have been able to stretch myself over the years, just because I have, I've been traveling for a year and a half. I worked at many different hospitals. And so I feel like I've been able to learn different things and maybe like combine that into like a conglomerate of knowledge that I use to make the best decisions for my patients, right? Like if you're working in the same place forever, you have that knowledge base that you're learning based off that one place. But once you are going to different places and having to modify and change the way you do things based off where you're at, you start to view things a little differently. Like, okay, this is why they view this way here, and this is why they view this way here, right? And so you get that overall view of the situation instead of just having that one view that you learned this one place, right? And so I think that that's something that's been positive for me. And so currently, I typically work right now with because I have a specific floors right now. I work with a lot of neuro patients, a lot of patients who have had strokes recently. A lot of my patients a lot of my patients do have chronic kidney disease, and they may be on dialysis. Not all of them are on dialysis, but a lot of them do have chronic kidney disease, or they have like diabetes. I deal with some cancer patients. A lot of my patients are on tube feedings because they can't eat by mouth, either because they can't meet their nutrition needs by mouth alone, because they're just so like they may have altered mental status, like they're just so out of it they can't even eat enough. Or maybe they have dysphagia, like because they had a stroke, and dysphagia is typically when you can't swallow anymore. And if you can't swallow, what does that mean? That means you're going to be at higher risk for choking. And if you're choking, that can create other issues, right? And so we don't want that. We want to try and prevent that. So we may put somebody on tube feeding for that. I deal with, I think I already said this, transplant patients, and then ICU on occasion. Typically, as a traveler, I haven't really been giving a lot of ICU. It just depends on what the needs of the facility that I'm at, right? At that time needs. Like there's been times where I've did nothing but ICU for 3 months straight. Do I fully like ICU? No, because it's very high intensity, and I'm just like, oh my gosh, like if I got to do one more tube feed or one more TPN, I'm gonna lose it. But it comes with the territory. And so if right now somebody was to ask me, so Jackie, like, what is your favorite area to work in? And as far as my experience, I mostly did adult clinical, and like I said, I did pediatric outpatient. Pediatric outpatient wasn't really for me, mostly because of having to deal with the parents. I love y'all, but y'all could be a lot. Okay. And that was a lot for me. And I went back to clinical inpatient adults at that point, because I was like, it takes a special person. Yes, it does. It takes a special person. And even being in clinical inpatient, I feel like there's ups and downs, right? I don't feel like any area as a dietitian like is perfect, like at all. But as far as me and my career and everything I'm doing, I feel like I'm content with where I'm at right now. I feel like for me, being able to have a team of coworkers that I enjoy and an area that I enjoy, and the flexibility, for a majority part of the flexibility that I like to an extent, I feel like that helps the job. I don't know if I'll ever specialize in anything. I don't know if I'll ever be like, I don't know, a cystic fibrosis dietitian or a transplant. Like, I don't know. I can't say that for me at this point. Never say never though, right? Like, you never know what you may find, what you may like later. Like, things change. I'm still growing as a dietitian. Because like I said, I've only been a dietitian since 2019, and even since then, I've grown so much. And so I'm still open. I want to see where things take me, and I just want to continue to learn, continue to grow. And I ask 1,000 questions because I want to learn and I want to understand. I feel like there's one thing that you can't do as a dietitian. You don't grow if you don't learn. You don't grow if you don't ask questions too. Because how are you learning if you're not asking questions? You have to ask questions. And so I'm always asking questions. I'm always trying to figure things out. I'm always trying to understand. Like I said, every hospital does things differently. And if there's something that's happening at a higher level, or they're doing things a different way, I want to be able to understand why. Because if you're doing something, especially, and this is something that I see a lot, is that if you're doing something and the other person can't follow up on or understand why you're doing it, then why are you doing it? If you can't even explain it well enough, then why are you doing it? You need to be able to understand why you're doing things and why you're recommending things. And so that's something that's important to me. So that's something I pride myself on. You're going to know why I did what I did, and you're going to understand it. And if you can't understand it, then I need to work harder and I need to do better. So that's just but that's just me. Not every dietitian's like that. And that's their prerogative, right? But I want you to be able to understand. So if I'm recommending tube feeds, diet education, a certain amount of calories, a certain amount of protein for you, there's a reason for that. And I want you to be able to understand my reasoning, right? So I hope that gives y'all like a good idea of what dietitians do and like what I do as a dietitian every day. I do the same things every day. And I hope this gives you a good idea of what that could look like. Like I said, there's other types of dietitians, but I'm mostly speaking from my own experience because like I can't speak for anybody else. I don't know what things may look like. All I could give you is like maybe my internship experiences. But even that was like maybe some of those were like only a few weeks, right? I can only speak about what I have experienced now and what's going on with me now. So I hope you guys enjoyed this. I'm glad I got to see you guys. I hope this at least gives you a good idea of what we as dietitians do and what I as a dietitian specifically do. Yeah, so ask me any questions. Follow me on Instagram. I don't know. I'll keep posting. I'll keep trying, really keep you guys up to date with what dietitians do and what I do specifically. And just, I don't know. We can have story time sometime, even if you want to. And I can tell you more about some of my patients and stuff like that. within HIPAA guidelines though, because ain't nobody's getting in trouble. And we're not doing that. Just in general, y'all. Be easy. But awesome, guys. I'm glad I got to spend this time with you. Have a wonderful evening, night, morning, whatever. Bye, you guys. Continue to do life with Jackie. Like, subscribe. See you.